Well, good morning, everyone. Like you said, I'm Dr. Nicole Johnson. I am currently serving as Associate Medical Examiner at the Pierce County Medical Examiner's Office in Tacoma. And this morning, we're going to talk about forensic pathology. So hopefully by the end of our little lecture here, you'll be able to tell everyone a little bit about forensic pathology, explain the difference between a coroner and a medical examiner, and then kind of describe an autopsy and why one may be performed. So the first question is what is pathology? Most people outside of medicine don't actually know that pathology is a medical specialty. And sometimes our clinical colleagues forget exactly what we do, but that's not their fault. It's not something that we really learn about very much in medical school, unless you already know from experience. Now, just doing a little Google image search, when you search pathology, this is kind of what you get, and it's what most people think of in pathology is we look at a lot of slides under the microscope, sometimes sit in dark rooms. Usually not. Most of us have nice windowed offices, but it is just a stereotype that follows us along. Now, pathology is defined as the science of the causes and effects of diseases, especially the branch of medicine that deals with the laboratory examination of samples of body tissue for diagnostic or forensic purposes. But more simply, pathology is the medical discipline that provides diagnostic and information to patients and clinicians. So there are two big umbrellas of pathology. First, clinical pathology and anatomic pathology. Clinical pathology is everything you think of about the lab. So it's the specialty that's concerned with diagnosis of disease based on laboratory analysis of body fluids, and it has multiple boarded subspecialties. They cover the blood bank and transfusion medicine, which most people don't realize, but then also everything you think of a lab. So clinical chemistry, hematology, if you or someone you know has ever gotten a lab report, the doctor's name who's on the report is a pathologist because they are the medical director of the lab. This also covers immunology, microbiology, hematopathology, and genetics. And now, anatomic pathology is more looking at the tissue both with your eyes and under the microscope with additional ancillary testing. So it's predominantly concentrated on diagnostics via macroscopic, microscopic, biochemical, immunologic, and molecular examination of organs and tissues. There are three big categories under anatomic pathology: surgical pathology, cytopathology, and autopsy. Surgical pathology, if you or someone you know has ever had a biopsy or a surgery in which an organ or tissue was removed, this goes to surgical pathology, where they will look at it grossly, say for instance, a cancer specimen. They will open up the specimen, look for the tumor, measure it, sample it, check margins, and all of this is reported back to the surgeon to guide their treatment. Also, molecular diagnostics are performed looking for targeted treatment. And there are boarded subspecialties under surgical pathology, dermatopathology, neuropathology, pediatric pathology. Hematopathology straddles both worlds. And then there are also fellowships in organ specialties, but they are not boarded. Cytopathology, it's the study of cells, so they typically deal with very small pieces of tissue, so fine needle aspiration. This is a subspecialty that they may see patients. They may go to the bedside to do a fine needle aspiration. They do rapid on-site evaluation where they may be called to radiology to let them know whether they got diagnostic tissue or not. And then autopsy, this may be done in a hospital setting or in a forensic setting. In the hospital setting, it's usually referred from a service or a family is interested in better documentation of their disease processes. So it is a service that may be performed at a hospital, whereas forensics is a little bit different, and we'll talk about that further. So how do you become a pathologist? So like most pathways to become a doctor, go to college, get a bachelor's degree, medical school, residency, and then fellowships. So residency in pathology can be combined anatomic and clinical pathology training, anatomic pathology training only, clinical pathology training only, or combined anatomic and neuropathology training. So for myself, I completed bachelor's degrees in human biology and anthropology at Michigan State University. I then went on to complete a master's degree in pharmacology and toxicology at Michigan State. I went to PNWU over in Yakima for medical school. And then I completed combined anatomic and neuropathology training at Virginia Commonwealth University in Richmond, Virginia, where I also served as chief resident. And then I just completed fellowship in forensic pathology. So I am board certified in anatomic and neuropathology, and I take forensic pathology boards in just over a month. So that's just kind of like a general path. Now for forensic specifically, you can follow 3 of the 4 paths. CP only does not cover autopsy, so you can't really use that to qualify for a forensic fellowship or to sit for boards. So what is forensic pathology? Now this is typically, when you ask someone about pathology, they might think about this because they're going to think about all of the medical examiners that they see on TV. So parents or grandparents up here, this is the grandfather of all medical examiners on TV, Quincy. The rest of these shows pictured, they're shows that are centered specifically on medical examiners, but other crime-related shows usually have a medical examiner or a forensic pathologist. So something like CSI, Bones, there's always a medical examiner that's involved. So you may see multiple disciplines in which forensic is applied. It just means that the application of their methods and expertise are applied to the criminal justice system. So there's forensic pathology, there's forensic odontology, forensic anthropology, there's even forensic botany, which is the study of plants. So in this case, in an autopsy or a forensic pathologist may be called to examine those who die suddenly, unexpectedly, or violently. And they have an expertise in determining cause and manner of death. Now, during fellowship, you receive extra specialized training in toxicology, ballistics and ballistics wounds, which is just a fancy term for gunshot wounds, trace evidence, serology, and DNA technology, and they typically serve as medical examiners. Now, this question comes up a lot, medical examiner versus a coroner. A medical examiner is a physician. They are not required to be a pathologist or specialize in death investigation. This is typically an appointed position. They investigate and examine individuals who die suddenly, unexpectedly, or violently, and they determine cause and manner of death. Now, in the United States, 21 states plus the District of Columbia have medical examiner systems, and 18 states have a mixed medical examiner coroner system. A coroner, however, is a public official that is appointed or elected. They are not required to be a physician or trained in medicine. They are called to determine if a death may be due to foul play, assign cause and manner of death, though they may employ a physician, pathologist, or forensic pathologist to perform an autopsy if there's a question in cause or manner of death. And 11 states have coroner systems. Now, this is just a map of the distribution of the United States and their systems. Here in Washington, we have a mixed medical examiner coroner system, and this is by county. By law, if a county has a population greater than 250,000, it must be a medical examiner county. So the 6 counties are Clark, King, Pierce, Snohomish, Spokane, and Whatcom. And by law, they must be a forensic pathologist or eligible to take forensic pathology boards. In a county that has a population of 40,000 to 250,000, this will be a coroner county. And in counties where the county population is less than 40,000, it is the prosecuting attorney. Now, this one is kind of going by the wayside, and some of the coroner counties are turning into medical examiner counties. And for the most part, the coroner counties are turning to the limited medical examiners in the state to perform their autopsies. So how are medical examiners notified of a death, and how do we decide which cases to investigate? So the office may be notified by EMS or law enforcement if they find someone who's deceased at home. If someone dies in the hospital, it may be a nurse or a physician. And this call will come in to a medico-legal death investigator. They are trained specifically in death investigation. They actually have a board, the American Board of Medico-Legal Death Investigation, and they may sit for an exam to become a diplomat of the board, and then they have continuing education for this. Now, after they receive the call, they will take information to decide whether to accept or decline jurisdiction. So typically they'll want circumstances of the death, the age of the individual, medical history, have they had any falls or trauma, do they have any known drug use, and based on that information, they will decide whether to accept or decline jurisdiction. So typically, say it's someone at home, but they were on hospice care, or they have significant medical history, like high blood pressure, coronary artery disease, cancer, COPD, will decline jurisdiction and let it go back to their treating physician. Whereas if it doesn't meet this category, then they will go and perform a scene investigation. This is a lot of photo documentation, talking to EMS, law enforcement, friends, family, anyone who's available to gather additional information. Lots of photos. If there's trauma, look and see if there's any cause for the trauma, if there's suspected drug overdose, is there any drug paraphernalia, are there medications, incorrect counts? And they'll collect all this information and then decide if it meets criteria for probable autopsy or to just release to a funeral home. And then if the answer is they probably need a postmortem exam, then they will transport them to the medical examiner's office. So what is an autopsy? So an autopsy is a specialized surgical procedure that is used to determine cause and manner of death. Now, the term autopsy comes from the Greek word autopsia, which means to see for oneself. Now, the autopsy is composed of an external exam as well as an internal exam. The external exam is kind of like a physical exam on a live person. You're still going to look at their eyes, nose, look in their mouth, look on their body, look for scars. Do they have any scars that would correspond to a prior medical procedure? Do they have any implanted devices? Do they have any identifying tattoos? Do they have any trauma? Do they have lower extremity edema, swelling that may be consistent with a heart problem? Is their chest expanded, maybe consistent with COPD? And all of this is documented, photographed as necessary, and evidence collection as necessary. The internal exam is where we actually look in the body to actually look at the organs with our eyes and take samples to possibly look at under the microscope. And again, there may be some evidence collection along the way. Now, there are 4 autopsy techniques that are utilized: the Virchow, Rokitansky, en masse, and en bloc. The Virchow technique is doing organ by organ, which means that they will remove one organ at a time. Rokitansky is in situ organ dissection, which means that the organs are left in place and then they are dissected. En masse means a single organ block, so this means that they will remove the neck organs all the way through the pelvic block altogether. And then en bloc is separate organ blocks, so just the neck, just the chest, just the abdomen, and just the pelvis. Keeping it all together helps to maintain anatomic orientation. I find this to be most useful in looking at trauma and wound paths, just to see associations and correlate with any external trauma. If there is no expected trauma, then doing the Virchow organ by organ typically saves a lot of time. Most of these are done by autopsy technicians within the medical examiner's office. So they're usually removing the organs, and then we are looking at the organs individually. Now, in a forensic autopsy, again, determine cause of death, manner of death, and another component is identification. Sometimes someone may be brought in just to be identified. We can do fingerprints, photo comparison. We can contact a forensic odontologist to do a dental record comparison. A forensic anthropologist can do a skeletal comparison with x-rays or a scout image from a CT scan. Also, a question about postmortem interval. One question that I get asked a lot from prosecuting attorneys and detectives is they want to know exactly how long someone has been dead. There is no exact science to determining this. It's in general, just a general category. Has it been a few hours? Has it been a few days, few weeks, few months? But there is currently no good scientific mechanism to determine the exact time of death unless it happened to be witnessed or caught on video. Another major component of forensic autopsy that brings it into the forensic autopsy realm is just identifying and documenting trauma. And then also ancillary testing is typically performed in a forensic autopsy and not in a hospital autopsy. Now, just briefly on trauma, there are 3 major categories of wounds: blunt force, sharp, and ballistics or gunshot wounds. Blunt force wounds include abrasions, so if you scrape your skin, a contusion, which is also known as a bruise, laceration, which depending on who you talk to, there's a different definition, but in the forensic pathology world, a laceration is a blunt force injury. Typically, you see this on the skull. They will be struck by a heavy object, and usually the question is a laceration versus a sharp force wound. And in a laceration, you will still see tissue bridging. So if a sharp instrument had been used, there wouldn't be any tissue. So it would still be semi-connected. And then also fractures qualify as blunt force wounds. A sharp force wound, kind of what it sounds like. A stab wound is deeper than it is wide. An incised wound is a wound that is wider than it is deep. And a chop wound is a sharp force wound, but with a heavy implement. So this is kind of like an axe wound, or say like a 2x4. It may cause a cutting, but it will also cause blunt force injury underneath. It may fracture. And then ballistics wounds, this is the area that we spend the most time with, is looking at entrance and exit wounds. Entrance wounds tend to be very circular, punched out, and it varies depending on how far away the weapon was discharged and what it may look like. A weapon that has been pressed up hard against the skull actually creates a significant defect, because even when a bullet leaves the barrel of a gun, there are a bunch of gases that come out and cause expansion. And so it can cause a more significant wound than you would expect. Exit wounds don't cause a punched out effect. It usually just causes a little laceration, so you can actually put the skin back together again. And range of fire is always a question. So with entrance wounds, a hard contact will make a big wound. And then you can also look for soot, meaning that the gun was very close, and it will leave kind of a dark material around the entrance wound. And you can also see stippling. That just means that the gun is about, on average, 1 to 3 feet away, and it will leave little powder marks around the wound. And then indeterminate range is when none of these features are seen, or if there was something in between the weapon and the skin. Now, do we do any additional tests aside from the autopsy itself? So there are several ancillary studies that we perform. We do toxicology on almost all cases. This is typically done on femoral blood, but we can also do it on spleen blood, liver. It can also be done on muscle and brain tissue, which is not very common, but it is available. Also may do vitreous chemistry if there's a question about dehydration or diabetic ketoacidosis. Microbiology, if we're concerned for meningitis, we can do a sterile swab and send it to a lab. Also DNA, we don't do this very often. Like the New York City office of the chief medical examiner, they actually have a DNA lab, so they do like seizure panels. If there's a sudden unexplained infant death, they'll do a whole exome sequencing just to see if they can find anything. Radiology is becoming more important in forensics. At King County, if it makes sense for the case, we coordinate with Harborview and we'll do a postmortem CT exam. The University of New Mexico has been doing postmortem cadaver CTs for about 10 years now. So it's a very useful tool. And down at Pierce, we're getting one next year, so we'll be able to start implementing that. Anthropology is also utilized aside from identification, also for trauma analysis. They're very good with skeletal trauma, and also just working up an identification if a skeleton is found. So now what? We've done the autopsy. What do we do after that? So the death certificate. So at the completion of the exam, a death certificate will be signed. But I have to make the note that medical examiners only sign death certificates for cases where jurisdiction was accepted. The majority of death certificates are not signed by the medical examiner. They can be signed by any clinician. It's typically someone's family physician or their specialist that they see the most. Most of them are signed by non-medical examiners. So what you primarily fill out is the time, date, location of death, the cause of death, manner of death, whether smoking contributed to the death, whether the individual was pregnant within the past year, if applicable, and then in the case of the medical examiner, if there's trauma, an injury description, and the time, date, and location of the injury. And then all of the death certificates now are signed electronically. This is just what it looks like in general for a paper copy if they were to print it out. So the cause of death and manner of death. So the cause of death is the underlying disease or injury process. So if someone has a long history of, say, high blood pressure and coronary artery disease, the most common cause of death would be listed as hypertensive and atherosclerotic cardiovascular disease. And then if it was someone who had been shot, then it would be just multiple gunshot wounds would be the cause of death. And that would be it. You can't just put cardiac arrest and or respiratory arrest because that is something that all deceased individuals have in common. You can list it just as long as you put something else after it. The manner of death describes the circumstances in which the death occurred. There are 5 manners of death: natural, accident, suicide, homicide, and undetermined. So in a natural manner of death, this is death that's caused solely by disease or a natural process. An accident is when what happened was not intentional, so there's no evidence that it's anything other than an accident. A suicide is when an injury or intoxication is a result of an intentional act to either cause self-harm and possibly cause death. And homicide is when death results from a volitional act committed by another person to cause fear, harm, or death. And undetermined is when you can't pick one of these. So an example to try to show the difference between them is if you were to find someone under a bridge and they had multiple injuries. It would be an accident if they were walking along and fell off. It would be a suicide if they jumped. It would be a homicide if someone pushed or shoved them off. And then undetermined would be if you didn't have any information. Now, an autopsy report is generated, list out the pathologic diagnoses. So even if it's something, this is based on external and internal exam findings, but if it is a trauma-related death, we still list out natural disease processes. We're still looking at the organs, so we'll still identify if they had hypertensive cardiovascular disease, if they had a tumor, anything like that will still get listed. As well as the cause and manner of death. Sometimes there's a narrative opinion of how we came to this. And then we also give ancillary test results. One component that sometimes scares people away from this is testifying in court. Typically, testify as a witness for the prosecution. They go over your qualifications, definitions, experience, and then you get to the autopsy findings. So most of what I've kind of touched on today is exactly what the questions I would be asked if I was in front of a jury. I see it as an opportunity to teach. So that's kind of how I look at it. And then you will get into your autopsy findings and you will be cross-examined by the defense. Sometimes it's just a question or two. Other times they may just try to poke holes or kind of get you in a gotcha moment, but that doesn't happen too often. So forensic pathology, if you're not aware, does have a contribution to public health. Here in King County, the medical examiner's office is actually within the Department of Public Health. They play a significant role in epidemiology. So data is collected from death certificates at the state and federal level. Data is collected to develop strategies to prevent disease or injury. So a lot of information came from the COVID-19 autopsies. Data about injuries led to seatbelt requirements, and also data from fire-related deaths led to the installation of smoke detectors in buildings. And then a lot of data about drug-related deaths. Now, this is just an example. This is an article that came out of the King County Medical Examiner's Office in relation with the University of Washington. This was published in The Lancet, and it was from the autopsies that they were performing, and they actually looked at the tissue and were reporting back so decisions could be made clinically. So a lot of the information was actually coming from medical examiners in the early days of COVID. And then here in King County, they have a live dashboard about fatal drug overdoses, and this is to kind of just keep public health officials apprised of like what we're seeing. They do in-house drug testing so they can let drug enforcement agencies know what kind of drugs that they're seeing, and just kind of help and try to stem the tide and identify areas. It's kind of been getting out of control in King County, as most of the country. Fentanyl is the most common drug identified in intoxication deaths, and then just opiates in general. Okay, so if you're interested in learning more, what can you do? So there are many resources. The National Association of Medical Examiners actually has a series of lectures for medical students on various topics that fall into the realm of forensic pathology. They also have educational cases that they post weekly that you can look at. And then also just resources about the profession in general. You can see what jobs are posted. They have training pathways, fellowship connections. It can be helpful. The American Academy of Forensic Sciences covers all of the realms of forensics. So they cover forensic pathology, anthropology, odontology, jurisprudence, so law, and they have a lot of resources as well. You can also reach out to a medical examiner's office to see if they allow observers shadowing or tours. It's a little bit more restricted, but if you express a lot of interest, if they have the staffing capabilities, usually they can at least arrange for a tour. And if you're interested in pathology in general, the United States and Canadian Academy of Pathology is a resource, as well as the College of American Pathology. They all have so many resources for students and a lot of free videos, and most of the conferences for these organizations are free for students. So with that, I think we might have a few minutes for questions.
I have two questions for you. Number one, I noticed on your title slide, it said that you were a doctor of osteopathic medicine, and I was wondering what led you towards that specific education track?
Well, the predominant feature was my husband got a job near Yakima, and there happened to be a medical school there. So that was the primary factor for that medical school choice, but also my family physician was a DO, and I just appreciated the more kind of hands-on part of medicine, and I actually use those palpatory skills with an autopsy, feeling for a fracture, or the pancreas really likes to hide in visceral fat, and just being able to use those palpatory skills to help identify potential injuries. So I feel like it's also served me in that realm as well.
Thank you. And then my other question was specifically in regards to the field of medical examination. You mentioned how you really only take a case if it's unexpected or violent or something like that. Mm-hmm. So I know something we've talked a lot about as a group is mental health and work-life balance as a physician. How do you manage that in a field where almost everyone who comes in is dead, pretty much, and as the result of usually cruelty from another person?
So it is difficult, especially when the death investigation system has been so overwhelmed with all of the overdose deaths. There's increase in homicides here in King County. So it's very difficult. I find that the easiest way to deal for it is to just try to leave work at work and make time for myself. There's been a real push in the field to focus on wellness and give people time off. I have a family. I always make time for my family, and I prioritize them. So when I'm at home, I'm with them. And just talking through it. Plenty of people do therapy. I think it's harder for the investigators because they're more the front line. I would say doing the exam isn't the hardest part, it's the family. So common conception in pathology is that we don't talk to people, you don't like people. In reality, we spend a lot of time talking to people. We spend a lot of time talking to clinicians to explain results so they know how to explain it to their patients. In certain fields, you still see patients. In cytopathology and transfusion medicine, you will go see patients. In forensic pathology, we have to be able to talk to a jury to help them understand, but we also have to talk to the family. And everybody handles death differently. Family members may call crying, they're so upset. They're very angry, been screamed at, yelled at, crying. It's difficult, and it's just everybody has their different way of managing it, but it is something that's recognized, and we're still trying to get better about it all the time.
Thank you so much.
You're welcome.
Can you tell us your name?
I'm Audrey Berry, and I also have two questions for
Yeah.
you. The first one is, how do you deal with irregularities in like your caseload? Because it's not like always the same.
So typically we share the load and we try to distribute so that way if someone has had a lot of cases, somebody else will pick up the slack. We've also, with the increasing caseload, we've been changing how we handle cases. So radiology has been very helpful in that. And with drug overdose deaths, if there's enough evidence to suggest it, they may not get a complete autopsy. And CT has also been helpful in trying to rule in and rule out autopsies. So that's been a big tool. That's what the University of New Mexico was using, where their cases reported doubled, but they were able to maintain their same level of autopsies by using their CT. So that's been an important tool, and that's how we're planning to use it in Pierce.
Thank you. And then my second question is, how do you work around when parts of the body are like very compromised, I guess, or like especially with substances, like when they're not easy to use or examine?
So we do the best that we can. I had a case where sodium azide was the suspected agent, and it's a chemical that's used in airbags. It's the explosive component, and it reacts to metal. So they'd ingested it. So we found plastic plastic forceps just to try to take a peek in the stomach, but we kept it contained, and then worked with hazmat and poison control and how they wanted us to handle it. We're not going to put people at risk. Also, we have isolation rooms. Some people have negative pressure rooms, and so that's how a lot of COVID autopsies were performed, were negative autopsy or negative pressure suites. The main goal is to keep everyone safe. We don't want to compromise anyone's safety. So we do what we can to protect everyone. Mm-hmm.
Any other questions? I have one. With the future generation with us, how is AI being implemented in your field?
So in forensic pathology, not so much, but in pathology in general, a lot of people, like when I was a resident, they did AIs to, we do immunohistochemical and histochemical stains, and one of the stains we use to identify a fungus in a specimen just has a lot of background noise, and it's sometimes very difficult. They were able to train the AI to recognize the pattern. They fed in everything, like this is a positive, this is a negative, and they were able to train it to figure that out. So it's a tool, it's not a substitution because it's not perfect. Digital pathology is becoming very common, so we scan a lot of our slides with the idea to be able to sign them out remotely and not have to push glass on the microscope. So AI is more of a tool in particular for us.
And then, okay. So again, thank you, Dr. Johnson. Before we have everyone come up and do a picture op and going to the bioskills lab, you guys remember your group numbers from yesterday? So what we'll do is, again, we want to make the most of the experience in the